Good afternoon. I'm Dr. Breelyn Wilky, and I'd like to thank the Desmoid Tumor Research Foundation for the invitation to provide the final results from our analysis of beta-catenin mutations as predictors of systemic therapy response for desmoid tumors. So as we know, desmoids can be characterized by activating mutations in beta-catenin, known as sporadic desmoids, or APC mutations that lead to Gardner's syndrome associated with FAP and a generally more aggressive course. And so some studies have suggested that recurrence-free survival is worse in beta-catenin S45F mutated desmoids compared to T41A. As we know, there's a 20% spontaneous regression rate for desmoid tumors, which has led towards early watch and wait approaches and reserving systemic therapies for symptomatic or radiographically progressing tumors. And since there are many systemic options ranging from traditional chemotherapy to newer TKI strategies, we wanted to ask the question if the particular mutation in a desmoid tumor might be used to guide the selection of treatment or identify patients with less favorable progression-free survival that should receive earlier treatment rather than watch and wait. And so as you can see, there are only a couple of studies that have investigated the correlation between mutation subtype and response to systemic agents. So in 2016, we were awarded a research grant from the DTRF to develop a retrospective database of desmoid tumor patients, identifying the mutation status and correlating to clinical outcomes by chemotherapy. And the data that I'll show today incorporates the final data set from Dana-Farber. The second aim of the grant was to develop an MRI, volumetric, and radiomic signature in parallel to assess radiographic response to treatment, again in comparison to clinical outcomes. So using REDCap, we all worked together to build a retrospective database identifying 309 desmoid tumor patients, 50 of whom were excluded for inadequate clinical data. Of 177 of the evaluable patients either had previously available mutation testing, or we obtained pathology archival samples and performed Sanger sequencing for beta-catenin and APC hotspot mutations. For patients with unsuccessful Sanger sequencing, next-generation sequencing was performed. Patients who did not have an identified mutation from either of these methods were considered negative. There were a total of 707 treatment lines identified among the patients, and our clinical endpoints included clinical progression-free survival, which was based on MD reports, taking into account patient symptoms, exam changes, and variably imaging studies. For a subset of patients, we had radiographic scans available for re-review by musculoskeletal radiologists, and we calculated RECIST 1.1 progression-free survival, as well as change in tumor dimensions with therapy. And finally, we calculated time to next treatment, which was independent of documented progression, as well as overall survival. And due to the numbers of patients, Cox proportional hazards models were feasible for these endpoints only in the first and second line of therapies. However, we did descriptively report all treatment lines by mutation status in an interaction analysis, recognizing that multiple therapies impacts progression-free survival. So here I'm showing you the Cox proportional hazards results for first-line clinical progression, which included 122 patients with mutation data. We built a model incorporating the mutation status, treatment regimen, which was consolidated into surgery, doxorubicin and dacarbazine, or ADIC, single-agent doxorubicin, which was primarily liposomal doxorubicin, sorafenib, methotrexate with or without vinca alkaloids, and other, which included other TKIs, tamoxifen, anti-inflammatories, and several other treatments. Sex, race, age, location of the desmoid, as well as FAP history were included in the model. And for second-line analysis, we also included time to initiation of second-line therapy as another variable. As you can see, the only mutation that impacted clinical progression-free survival in the first line was APC mutations. With regards to treatment, essentially all therapies had a decreased hazard ratio relative to surgery, which was largely confirmed in the multivariable analysis, but only ADIC and single-agent doxorubicin maintained statistical significance. Similar findings were observed in second-line clinical PFS analysis, as well as RECIST 1.1 and time to next treatment analyses. Essentially, ADIC and single-agent doxorubicin maintained their robust activity regardless of mutation status. These observations were also seen when we compared mutation status across all lines of treatment using the interaction analysis. Essentially, no significant differences were observed with clinical progression-free survival for any of these treatment regimens. However, we did notice an interesting trend with sorafenib, where all of the patients with S45F mutations did not demonstrate clinical progression. However, this is an extremely small number of patients, and this will need to be verified in larger studies, particularly, or maybe with potentially from correlative samples from Dr. Gounder's recent trial. In his overall survival analysis, we noted that both APC and other mutations, as well as a mesenteric or other location, were associated with worse overall survival. So obviously the limitations of this study are significant, including its retrospective nature. Even with multi-institutional collaborations, these are still rare diseases and patient numbers were a challenge. Older pathology specimens often failed sequencing. There's significant subjectivity in both physician and patient decisions for treatment, and gathering accurate and robust clinical data is challenging. And in looking at the institutions that saw the patients in this study, we were really seeing the worst of the worst. And we don't see the patients who will do well with surgery, especially if it's performed in the community. And so the full report of this analysis has been submitted to CTOS in abstract form, and a full manuscript is in preparation, led by Mike Nathanson at Dana-Farber. So the second aim of the grant was looking at MRI volumetrics and radiomics. As you know, MRI is very useful at detecting increasing collagenization within desmoid tumors that often corresponds with reduction in active tumor cells and the induction of quiescence. And we typically are looking at T1 weighted contrast enhancement and T2 hypodensity. Importantly, size-based criteria for response, including RECIST 1.1 or WHO criteria, neglect the quality and appearance of the tumor. And so this study included 27 desmoid patients from the University of Miami cohort that were followed for an average of 4 years with at least 3 serial MRIs. These were all extra-abdominal and all sporadic, and underwent segmentation for volumetrics as well as radiomics measurements. So what do I mean by volumetrics? Well, as I mentioned, with RECIST 1.1 criteria, we're looking at the longest diameter of the tumor, which neglects changes in the shape or even the shorter diameter. And so here in volumetrics, the tumor volume is outlined in red, and every pixel of this tumor can be counted and graphed on a histogram, which quantifies the different signals and assigns it to various musculoskeletal structures, including the collagenous compartment, or inactive, or the more enhancing or tumored compartment. And so looking at this patient who had serial MRIs, you can see the tumor volume outlined in red. To begin with, most of the tumor is enhancing and falling into the tumor compartment, whereas towards the end, after the tumor is collagenized, basically all of the signal is clustered more at the far end in line with muscle tissue. So looking at this another way, you can do volume curves here showing the active tumor volume in orange decreasing over time, or the collagenous volume increasing over time shown in gray here. And so my colleague, Dr. Tai Sobowang, and his group completed this volumetric analysis on these 27 desmoid patients. And he ultimately showed that for patients who would ultimately achieve a traditional RECIST partial response, defined as tumor shrinkage of 30%, the vast majority showed a change in tumor volume of at least 50% prior to the RECIST partial response. The average time to reaching a volumetric partial response of 50% was 1.1 years compared to 2 years for the size-based RECIST diameter criteria. And so looking another way, Kaplan-Meier curves for RECIST progression-free survival show that patients who had a volume decrease of 50% at 1 year had favorable RECIST progression-free survival with a trend towards significance. He also went on to study radiomics features, which are a series of MRI calculations that investigate and characterize textural features in the tumor, and he correlated these against the maximal change in tumor diameter. I won't go through these in detail, but the take-home point is about 50% of these different markers were correlated with changes in tumor diameter, particularly in a subset called the NGTDM. And this specific data set has also been shown to be helpful in other types of cancer imaging. And so this may be a more limited and robust tool set for future study for desmoids. And so this manuscript has also been submitted and will hopefully be published soon. So in summary, our data suggests that mutation status does not seem to drive recurrence or response to individual therapies as much as other factors, except for APC desmoids. Most chemotherapy regimens remain active across the mutations, and again, the best responses have been seen with ADIC or single-agent doxorubicin. With more patients, I suspect this sorafenib will also be similarly active across patients, but we are intrigued by the evidence of activity in S45F mutated patients in this study. We do need further validation with a larger data set. Additionally, we have not had any or very few patients in this data set treated with more novel therapies such as nirogacestat, and so this also raises a question of whether there's a potential sensitivity with different mutations. And finally, MRI volumetrics and radiomics likely are more sensitive tools to detect early response in desmoid tumors. However, the method is very time intensive and challenging for real world practice. There are many, many people who have supported this endeavor, and on behalf of all my colleagues, I'd like to thank the DTRF for the opportunity to conduct this research. Thank you very much.